All right, so today we're picking up with Haemophilus influenza type B. So when we talk about Haemophilus influenza type B, it has nothing to do with the flu. It's a bacteria that is gram-negative. It's a gram-negative cocci to be precise. And it can cause things ranging from pneumonia to meningitis, epiglottitis, ear infections, otitis media, um, pericarditis. It can cause um, simple things all the way to life-threatening disease. It is spread through contact and droplet. Um, so the main things that we worry about, are meningitis, epiglottitis, and pneumonia. Disregard where on your PowerPoint where it says CHIB VIS, that is something that I did not give you, just disregard that. Most children with disease caused by HIB need care in the hospital, unless it's something like an ear infection. But even with treatment, as many as 1 out of 20 children with HIB meningitis will die. So that's 1 out of 20 if they have HIB meningitis. But also, as many as 1 out of 5 children who survive HIB meningitis end up with brain damage or deafness. So when you think about why we have a vaccine for this, back in the early 80s and late 70s, when I was a child, HIB meningitis was what we were afraid of. That's what, would shut down the schools whenever a child tested positive for HIB meningitis, and everyone was afraid because it's so deadly. So now all children are vaccinated with the DTaP HIB vaccine, and HIB meningitis is not nearly as common. Now we have a new type of meningitis that is more common than HIB meningitis. But that kind of explains why we have the vaccine for that, not only to prevent meningitis, but also epiglottitis. When we look at HIB in the CSF, so this is actually an image under the microscope of cerebrospinal fluid in a child with HIB meningitis, and you can see that we have our gram-negative cocci and chains obvious in our CSF. This slide shows you the incidence of HIB as far as invasive disease from 1983 to 2016. So when you look here at 1983, 85, 87, 89, you can see how prevalent it was. And then when we started vaccinating, ensuring that children were vaccinated, the incidence of HIB meningitis dropped significantly, and epiglottitis, any type of invasive disease. And then 2011 through 16, it has started to make somewhat of a comeback. So the epidemiology in the United States has shifted since the introduction of the vaccine. We've been using the HIB vaccine in children since 1987, and we've been giving it to infants since 1990. So you can correlate these statistics with those facts. So since we started using the vaccine, the annual incidence of invasive HIB disease in kids less than 5 has decreased by like 99%. But now there's another type of HIB, they call it non-typable H influenza, that causes the majority of invasive disease related to HIB amongst all age groups in the United States. So in developing countries where they don't have routine vaccination programs, HIB remains a major cause of lower respiratory tract infections in infants and children. So it's a major cause of pneumonia in developing countries. In the United States, HIB disease is not common. It's primarily going to be seen in under-immunized children and in infants that are too young to have completed the series. Then there's that non-typable H influenza that causes like 30 to 50% of our acute otitis media and sinus infections in kids. When we have kids who get recurrent otitis media, Hib, this non-typable Hib is a common cause. Here is an image of brain tissue that has been affected by Hib meningitis, and obviously this is post-mortem, and you can see here where our brain tissue has just been liquefied by the bacteria. And then this is an image of an infant who is suffering from septicemia or bacteremia from Hib meningitis, whether it's from the disease itself or the vasopressors that were being used to maintain blood pressure, and the resulting vasoconstriction to the extremities has caused a lack of blood flow. Okay, so moving on to rubeola, which is the cause of measles. Nearly everyone in the United States got measles before there was a vaccine, and hundreds of people died from it every year. But today, most doctors have never seen a case of measles. Measles is an acute febrile rash illness with an attack rate of approximately 90% within the household. So if one person in a household contracts measles, it is so contagious that we can pretty much guarantee that 90% of the people in that household will contract measles. The symptoms appear 7 to 14 days after contact with the virus and typically include high fever, cough, runny nose, and watery eyes. And if you look at your slide, you see the high fever and the 3 C's: cough, conjunctivitis, and coryza. Conjunctivitis is our red watery eyes, and then the coryza is our runny nose, and we have the cough. So the 3 C's: cough, conjunctivitis, coryza, and high fever. The measles rash appears 3 to 5 days after the first symptoms. So measles can be really dangerous, especially for babies and young children. So that when we talk about that high fever, it can spike to over 104 degrees. Measles is a virus, of course, and it, predominantly is considered a respiratory illness, and it is one of the most contagious diseases known to man. These tiny white spots called Koplik spots may appear inside the mouth 2 to 3 days after symptoms begin. 3 to 5 days after symptoms begin, a rash breaks out, and it usually begins as a flat red rash with spots that appear on the face, around the hairline, and spread downward to the neck, the trunk, and then out to the arms, legs, and feet. Sometimes there are small raised bumps that appear on top of the flat red spots. The spots may become joined together as they spread. And once that rash appears, the fever may spike to over 104 degrees Fahrenheit. So Koplik spots go with measles, and the rash appears 3 to 5 days after symptoms begin. Once that rash appears, the fever can really spike. So here we have an image of a child. And so remember, your spots typically begin around the hairline and spread downward from the face to the trunk and then out to the arms and legs. And all of these spots can join together to where you have one great big rash. Here we have this slide shows the number of measles cases from 2010 to 2019. And we see 2010, we had a spike in 2011, a big spike in 2014, another one in 2018. So measles is definitely an issue for our country. And like I said in one of the previous slides, one of the only things that prevents us from having an all-out epidemic is the fact that these cases are mainly in clusters, and they do not become an epidemic because of the large number of people that we have that are immunized, and they protect us as a whole. It's called herd immunity. So the United States has had more than 1,000 cases of measles in 2019. Of course, now we're in 2020. This is the greatest number of cases reported in the United States since 1992 and since measles was declared eliminated in 2000. So in 2000, measles was actually declared eliminated in the United States, but from January 1 to October 1 of 2019, a total of 1,249 cases and 22 different outbreaks were reported in our country. So that was the second highest number of reported outbreaks since measles was declared eliminated. This is a flyer that is produced by the CDC to educate the public. It reminds us that it is very contagious. Remember, measles is known as the most contagious disease known to man. It spreads through the air. So when a person coughs or sneezes, it is so contagious that if one person has it, 90% of people, no matter the age around him, will also become infected if they're not immunized. Another flyer, measles anywhere is a threat everywhere because of international travel. Because measles is still common in many other countries, when an unvaccinated traveler brings the disease into the United States, it can spread to people who are not immunized. So there are lots of communities where people are not immunized, whether it's an Amish community or some other type of community where they don't believe in vaccinations or modern health care. And then there are those people who do and just choose, who do believe in modern healthcare, but are anti-vax. And typically when we have an outbreak, it is within these communities. All right, so the mumps. You remember that our MMR includes our measles, mumps, and rubella. So we talked about measles, now we're on to mumps. Before the United States mumps vaccination program started in 1967, about 186,000 cases were reported yearly, and many more unreported cases were occurring. So what is it about mumps that can cause a problem? Well, it can cause complications such as permanent deafness in children, and occasionally it can cause encephalitis, which could result in death. Since the pre-vaccine era, there has been a more than 99% decrease in mumps cases in the United States. From year to year, the number of mumps cases can range from, a couple hundred to a couple thousand. But comparatively speaking, it is much lower than it was pre-vaccines. However, outbreaks still occur even among highly vaccinated populations. So we do still see it. So take note in this picture, we have this swelling area here that we're going to talk about, and then we have our little chipmunk baby, and we're going to talk about what is causing these symptoms. So mumps is a virus, and it causes painful swelling, pain, tenderness, swelling in one or both parotid salivary glands. So these are in our cheek and jaw area, our salivary glands and our parotid glands. So pain, tenderness, and swelling. The swelling usually peaks in 1 to 3 days and then subsides over the next week. That swollen tissue pushes the angle of the ear up and out. And as the swelling worsens, you can't even see that angle of the jawbone anymore. The angle disappears. And sometimes the jawbone cannot even be felt because the swelling of the parotid gland is so extensive. One parotid may swell before the other, and in about 25% of the patients, only one side swells. A big danger for mumps is the possibility of deafness in children. So dying from mumps is not really our primary concern. It's more the possibility of leaving a child deaf. Also, it can cause swelling of the testicles and the ovaries. So here is a CDC flyer of our little chipmunk. Just to remind everyone, it says mumps can really ruin a selfie because, you know, it's just showing how it causes the swollen jaw and the puffy cheeks, and that the MMR vaccine is the best protection against mumps. And as far as our testicular swelling, I like this one. The swelling's not so bad. It's the severe testicular pain. Protect yourself against the mumps. Get immunized. So this is called orchitis. Orchitis occurs in approximately 20 to 30% of unvaccinated males and 6 to 7% of vaccinated males that are post-puberty that have been vaccinated. In 60% to 83% of males with mumps orchitis, only one testes is affected. Mumps orchitis has not been linked to infertility, but it may result in testicular atrophy and hypofertility. So I always tell the story. We had a student from South America who told a story of her little brother. When she was younger, her little brother had contracted mumps and was jumping on the bed, and she spoke Spanish, and she did it so well. I wish I could speak Spanish. She mimicked her mother, how her mother had come into the room just to fussing at her little brother in Spanish, telling him to stop jumping on that bed, or the sickness would go to his balls because they knew that mumps can cause swelling of the testicles. And the misconception was that jumping on the bed could encourage the mumps virus to attack the balls or the testicles. I shouldn't say balls. I'm so sorry. Anyway, that's just our little fun fact. Okay. So mumps cases in our country as of February 25th, 2017, look above Louisiana. It's crazy to think that Louisiana reported 0 cases in the same year that Arkansas reported over 300 cases. People who previously had 1 or 2 doses of the MMR can still get mumps and transmit the disease. During a mumps outbreak in highly vaccinated communities, the proportion of cases that occur among people who have been vaccinated may be high. This doesn't mean that the vaccine doesn't work, that the vaccine is ineffective. The symptoms are generally milder and complications are less frequent in vaccinated people. So it's still in your best interest to get the vaccine, number one, to support herd immunity and decrease the chance that you're going to spread the disease. But also, if you do get it, your symptoms will be less severe. All right, rubella. Rubella is the third part of our MMR. Rubella is known as the German measles or 3-day measles. The main concern with rubella is that it can be devastating to unborn babies. It's rare for it to really make children very sick if they catch it. It's more about pregnant women being exposed to the virus. Before the rubella vaccine was licensed in our country in 1969, rubella was pretty common. It occurred primarily among young children. It was declared eliminated from the United States in 2004. However, it is still commonly transmitted in many parts of the world. As a result, less than 10 cases, and usually those were import related, have been reported annually in the United States since it was declared eliminated. So don't be confused or don't be misled. If just because something has been declared eliminated, it does not mean that it's not still happening or that it can't still happen. So rubella has been declared eliminated, but yet we still have cases reported annually in our country. An epidemic of rubella in 1964 through 1965 infected 12.5 million Americans, killed 2,000 babies, and caused 11,000 miscarriages. Since 2012, 15 cases of rubella were reported to the CDC. So it's a big deal. Pregnant women who contract rubella are at risk for miscarriage or stillbirth. Their developing babies are at risk for severe birth defects with devastating lifelong consequences. Infection with rubella virus causes the most severe damage when mom is infected early in pregnancy, especially in the first 12 weeks or the first trimester. From 2005 to 2015, 8 babies with congenital rubella syndrome have been reported in the United States. So that's in 2005 to 2015, we have 8 babies with congenital rubella syndrome. So that means they were exposed in utero, they survived, but they had symptoms of this syndrome such as deafness, cataracts, heart defects, intellectual disabilities, and so forth. Although specific symptoms can be treated, there is no cure for this syndrome. Polio. Polio is an enterovirus. And this is where, when I talk to you guys about educating our families when their child is diagnosed with rhinoenterovirus or just enterovirus, we have to be careful when we print off educational material, because technically polio is an enterovirus, and we don't want to mislead the family and create a fear that their child has polio. Polio was once considered one of the most feared diseases in the United States. In the early 1950s, before polio vaccines were available, polio outbreaks caused more than 15,000 cases of paralysis every year in the United States. But once we started giving vaccines, specifically that inactivated polio virus vaccine, or IPV, in 1955, and then they introduced the oral polio vaccine, OPV, in 1963. Since that time, the number of cases fell rapidly to less than 100 in the 1960s and fewer than 10 cases in the 1970s. So we went from 15,000 cases of paralysis each year to less than 10 in the 1970s. So the vaccine is very effective. Poliomyelitis, interestingly, comes from the Greek term polios, meaning gray, and myelos, meaning marrow, because poliomyelitis is when the virus actually attacks the spinal cord and the brain. So this is just because you contract polio does not necessarily mean you are going to have poliomyelitis, which leads to the paralysis. So you can have polio and not become paralyzed, and we'll talk about that more in a minute. So let's look here at this picture. In 1988, you can see that in pink, we have countries that had never eliminated polio versus countries that had. We have had eliminated polio by 1988. And then in 2014, look, there are only a handful, was that 3 countries where polio has still not been eliminated. So this is as of April of 2014. So that is very good news. So most people who get infected with the polio virus, when I say most, I'm saying 72 out of 100, about 72% of people who get infected with polio will not have any symptoms, nothing. About 1 out of 4 with polio virus will have flu-like symptoms, and that could include things like sore throat, fever, nausea, headache, bellyache. They last 2 to 5 days and then they go away on their own. So you could have technically had the polio virus and not even known it. But a smaller proportion of people with this infection will develop other more serious symptoms that affect the brain and the spinal cord. Paresthesia, meaning that pins and needles type feeling in the arms and legs. Meningitis occurs in about 1 out of 25 people with a poliovirus infection. And then paralysis, or just a severe weakness in the arms, legs, or both, occurs in about 1 of 2 every 200 people with the poliovirus infection. So that's 1 out of 200. Most people just have flu-like symptoms, but 1 out of 200 can develop paralysis or a severe weakness. Paralysis is the most severe symptom associated with polio because it can lead to permanent disability and even death if it affects their respiratory muscles. Between 2 and 10 out of 100 people who have paralysis die because the virus affects those respiratory muscles and they can't breathe. So that's between 2 and 10 out of every 100 who have paralysis. Note that poliomyelitis is defined as the paralytic disease, and we've shortened that to polio. So just be aware that the polio virus is not necessarily the same as poliomyelitis. Poliomyelitis is what we call the polio virus once it has attacked the brain or spinal cord. So only people with the paralytic infection are considered to have polio when we talk about it in general. I like this slide. I know it's kind of hard for you to see. Let me see if I can make it a little bit bigger. So this talks about poliomyelitis and how it spreads and how contagious it is. So it's very contagious. It spreads through person-to-person contact. So our slide says the poliovirus enters the body through the mouth, usually from hands contaminated with the stool of an infected person or by ingestion of contaminated food or water. Then the virus is going to live in an infected person's throat and intestines. So it enters the body through the mouth and spreads through the contact with feces of an infected person, and though less common, it can spread through droplets from a sneeze or cough because it lives in your throat as well. You can get infected if you have feces on your hands and you touch your mouth, or if you put, objects in your mouth like toys that are contaminated. The poliovirus travels to the intestines and attaches to the intestines where it replicates, and it can spread from those intestinal walls into the bloodstream. So in 99% of cases, the poliovirus causes only the flu-like symptoms or none at all. But in 1% of the cases, the poliovirus spreads from the bloodstream to the central nervous system. It then attacks the nervous system, destroying nerve cells in the spinal cord. It may destroy the nerve cells governing the muscles necessary for breathing, and the muscles in the limbs, most often the legs. It is highly contagious. Even in mild cases, the poliovirus is excreted in the feces that can contaminate hands, food, and water. So an infected person could spread the virus to others immediately before and about, up to 2 weeks after the symptoms appear. It can live, the virus can live in an infected person's feces for many weeks, and it can contaminate food and water in unsanitary conditions. Even if you don't have symptoms, you can still pass the virus to others and make them sick. And something you may see in your career is post-polio syndrome. And it begins 15 to 40 years after that initial infection. Even children who seem to fully recover can develop this syndrome as an adult, where they all of a sudden have new onset muscle pain, weakness, or paralysis as an adult. And that's called post-polio syndrome. This syndrome affects 25 to 40 out of every 100 polio survivors. So that's crazy. Up to 40% of polio survivors are affected by post-polio syndrome. There are other non-polio enteroviruses. These are the ones that we see more commonly in the hospital. They cause 10 to 15 million infections and tens of thousands of hospitalizations in our country every year. Most people who get infected with these viruses don't even get sick, or they just have a mild common cold-like illness. But as you know, infants and people with weakened immune systems do end up in the hospital with non-polio enteroviruses. So when we educate these families, we have to clarify that this is a non-polio virus. Let's see. There is a theory, another fun fact, non-polio enterovirus infections may play a role in the development of type 1 diabetes in children. And that's just a theory that I read about. It is the cause of hand, foot, and mouth disease and quite a few other things. So enteroviruses spread just like we talked about with polio. You know, you may not be able to see visible stool on your hands after you change a baby's diaper, but if you don't wash your hands, there's no guarantee that you do not have, that you're not contaminated. You can get exposed to the virus by having close contact, such as touching or shaking hands with someone who is contaminated, and then touching your eyes, your mouth, not washing your hands before you eat, things like that. And then whether or not you have symptoms, then you can continue to spread the enterovirus. One enterovirus that we know about that made the news is called EVD68. It was first identified in 1962 in California, and it is one of the non-polio enteroviruses. During 2014, there was an outbreak of EVD68, and it was reported just way more often than it had been in previous years. In the summer and fall, the United States experienced this outbreak associated with severe respiratory illness. Then from August 2014 to January 2015, the CDC got involved. It confirmed 1,300 people in 49 states with respiratory illness had been diagnosed with EVD68, and almost all of the confirmed cases were among children, many who had asthma or a history of wheezing. About 40% tested positive for an enterovirus or rhinovirus other than EVD68. So if you don't have immunosuppression, if you're an adult, if you don't have asthma, you may just have had mild symptoms, whereas many of the children that did fall into this high-risk category had severe symptoms requiring hospitalization. And this is a contact droplet scenario as well. EVA71 is the strain of enterovirus that causes hand, foot, and mouth disease, which we have a good picture here where we can see that. And it's a mild illness. It can rarely cause more severe symptoms like meningitis or even acute flaccid myelitis. We had some episodes of that in 2016, and I remember seeing it on the news. It is still something that is out there that can happen as a result of enterovirus. Acute flaccid paralysis is where, for whatever reason, um, the child, if their respiratory muscles are affected, it can, it can make them end up on a ventilator. And it's just caused by an enterovirus. And it makes me remember that enterovirus is the cause of it because enterovirus is related to polio. Um, the paralysis usually is temporary, and as the child recovers, it goes away. So rhinoviruses and enteroviruses are in this family of picornaviruses. You don't have to remember all that, but just so you know, you may ask, why do we say rhino entero? Why don't we know, is it one or the other, or is it, sometimes it's just very hard to tell because they're so, you can have a mixed infection. You can have rhino entero and RSV. You can truly have rhino and entero, but sometimes we just can't identify which picornavirus it is. Maybe it's rhino, maybe it's entero. So, and we just don't know. That was the point of this slide. All right, moving on. Human metapneumovirus. It is also one of those common cold viruses, but it can cause more significant upper and lower respiratory diseases. It is in the same family as RSV. So the symptoms are a lot like RSV. It can progress to pneumonia just like RSV. Human metapneumovirus was most recently discovered. It was one of our viruses that is fairly new. It was discovered, I want to say, in Sweden or Switzerland in 2001. And we aren't 100% sure how it spread, according to the literature that I've read, but because it is so similar to RSV, we assume that it is spread via droplet and contact, most likely contact. Parainfluenza, if you will recall, is a common cause of croup, but it can, it has like 4 different strains: parainfluenza 1, 2, 3, and 4. Parainfluenza type 1 is the most common cause of croup, and then there are other strains that can cause bronchiolitis and pneumonia. Most children 5 years of age and older have antibodies against type 3, and approximately 75% of us have antibodies against type 1 and 2. So that means that we have seen it by the time we're 5 years old. Adenovirus. There are a lot of different types of adenoviruses. Something that's interesting to me is that they are resistant to disinfectants. So we really have to clean, do a good job cleaning when we know we have had a patient with adenovirus. It also causes respiratory illness and is spread via contact and droplet. So one of the things about adenovirus is that your symptoms could just be tummy related, acute gastroenteritis. If you have a patient come in with, or maybe you're working in a clinic and the pediatrician says, you know what, their blood work looks viral, they've got the red eyes and they've been vomiting, they've got a fever. These are our main symptoms: conjunctivitis and gastro symptoms. You may hear the pediatrician say something like, it's probably one of the adenoviruses. We're seeing a lot of that right now. So I've heard that. And once I studied up on adenovirus, it all started to click and make sense. Yes, adenovirus can cause flu-like symptoms, sore throat, things like that, but it is also a common cause of acute gastroenteritis with conjunctivitis. So there's a big range of symptoms there. So now we're going to talk about meningococcal disease. I want you to watch a video. Let's see. Let's go ahead and do that now. And this video is about a little boy named Robbie. Let me see.
I'm Robbie and I go to Bowburn Infants Nursery School and I'm 7 years old. I like swimming with balls in the swimming pool. I like diving and I like jumping in the swimming pool, going under the water, getting things. And I've never been scared when I'm swimming. And I play football club at school with all my friends. And Stephen makes my legs. He showed us a piece of paper and it had lots of colours on, and I used black and blue.
My name's Jill Jones, and my son Robbie, when he was 21 months, he was diagnosed with meningitis. Robbie was in hospital for 8 weeks. The weekend that Robbie was poorly, he just had a bit of a temperature, but he was teething as well, so we didn't really think anything of it. We put him into bed with us, just to keep an eye on him really. And then when Robbie's dad woke up at about 5 o'clock in the morning, and it looked like Robbie had like shadows over his face, and it was just getting into like daylight. And he said it for some reason. He said, "No, it just doesn't look right." And Robbie never had a rash yet to this day. It was just bruises. He looked like he'd been in he looked like he'd been fighting with Mike Tyson. Meningitis never ever struck us at any point. We just thought it might have been like an allergic reaction. So we got ready and we rang for Wayne's mum to come and see my daughter Abby while we took him to the hospital. And when Wayne's mum came round, she said, "No, just to be on the safe side, let's ring an ambulance." When the ambulance came, they did the tumbler test, and yeah, like the paramedic just said, "Look, we need to get him in the ambulance now." He said, "I need to give him like an antibiotic injection." And he said, "If it's what I think it is, it'll help. If it's not what I think it is, then it won't do him any harm." And then we got up to the hospital, like accident emergency, and when we got there was about 12 doctors waiting around a bed for him. And after we'd been in there for a while, there was like a consultant came to see us, and he'd said, "Your son's dying, he's got meningitis." And that was just absolutely horrific, nearly killed us all. They said, "We're going to take him to Newcastle." They said, "Go home and pack some bags because you're going to be with us for a while." And when we went in, we actually walked straight past him because his body was that much filled of like fluid. He was double the size. I mean, he was only like tiny anyway, but he was absolutely enormous. And he was just like a little Michelin man lying in the bed. And they'd said, basically, we've got to tell you the truth now. We can only give him 5% chance of survival. So that was when they decided to take him down. That was after he'd been in hospital for 2 weeks. And I mean, the doctor actually told us, he said, "Oh, we'll take him to theatre, and we'll be back within a couple of hours. Hopefully it won't be too bad." But he was gone about 5.5 hours. And then when we came back, he was back in intensive care, and it was just awful, so scary to think something, you don't expect anything like this to happen. And, it was just awful thing. 21-month-old, he hadn't been walking very long. And so it's all coming back. Robbie lost his left leg below the knee and then his right leg above, and the fingertips on his left hand. They had to start physio straight away because, I mean, he'd been through that much, he couldn't even sit up by himself. I mean, the only thing he would eat would be Kit Kats and Haribos. So every time somebody came to visit him, that's all we had Haribos all over the place. Tony Anton's took everything in his stride. Nothing's phased him whatsoever. Nothing at all. Robbie was taken to the hospital on the 7th of July and we booked our wedding for the 2nd of August. So unfortunately we had to cancel that. But then we were determined that, you know, once Robbie was up and on the go, that he would walk me down the aisle. So the following year, it was like the 4th of July, the year after Robbie was poorly, we did get married, and Robbie did walk us down the aisle with his walking frame. And I mean, it was an absolutely fantastic day. A lot of tears and a lot of joy as well, because I still had my boy there to walk us down the aisle. Nothing will ever get in his way. Nothing will stop him from doing things, and I think that's, you know, it brings us, like, you know, it brings us alive as well, because like you say, we didn't want him to be a little boy sitting in the corner when he lost his legs. You know, he's just up, he's on the go, and there's no stopping him.
So if you think back to the images or the image that you saw on the previous slide, let's see, let me fix this. Of the little baby with the hands that had turned those awful colors. That was a result of meningococcal disease. So back in the day, the disease that we worried about causing meningitis, like I said, was HIB, Haemophilus influenza type B. Now, the biggest threat to our children is Neisseria meningitidis. That is our biggest concern with meningitis and septicemia. The bacteria, about 1 in 10 people have this bacteria. They're called carriers, but it can become invasive. Why it happens in some people and not others, I do not have the answer for that. People can spread it easily through secretions, but generally it takes close contact, like coughing or kissing, or lengthy contact. So if you have someone who's diagnosed with bacterial meningitis, these days you will see that only the close contacts of that person, such as family members, boyfriends, girlfriends, are treated with antibiotics, not the entire class, you know, class of students and things like that. Fortunately, they are not as contagious as those germs that cause, you know, the common colds, like our rhinoviruses and adenoviruses and RSV, things like that. People don't catch the bacteria through casual contact, or it's, you know, it's not airborne. So it's just those close contacts should receive antibiotics. And here in this image, we have a 4-month-old female that has developed gangrene of her hands and lower extremities due to meningococcemia. This is the bacteria, Neisseria meningitidis. It is a gram-negative diplococci, and it is the germ responsible for meningococcal meningitis. Symptoms include fever, headache, stiff neck, nausea, vomiting, photophobia, altered mental status. In an infant, they could be have decreased activity, irritability, vomiting, they won't eat, possibly that bulging anterior fontanelle, that is a late sign. In young children, doctors will also assess their reflexes for signs of meningitis. So there is septicemia, which is also known as meningococcemia or bacteremia due to meningococcal disease. And then there's the meningitis. So with septicemia, the bacteria are in your bloodstream, just like any type of sepsis. And you have here a list of symptoms that this patient could have. And let's just go to this next slide. I'm going to make it bigger for you. these are the two most common manifestations of meningococcal disease: meningococcemia, which is the blood infection, and meningitis. Okay, so you're pretty familiar with the symptoms of meningitis, but this may help clarify it. It's broken down into symptoms of just the meningococcemia and the symptoms of just meningitis, and then some symptoms that are common in both. And this is when she was talking about the shadows on Robbie's face. This purplish rash is a telltale symptom of meningococcemia. You can have both. You can have meningococcemia and meningitis. So this is a good handout to refer to. About 10 to 15 out of every 100 people with meningococcal disease will die. Long-term disabilities from having meningococcal disease include loss of your limbs, deafness, nervous system problems, and brain damage. All 11 to 12-year-olds should get a single dose of the meningitis vaccine. It's called MenACWY. The CDC recommends also a booster dose at age 16, and that will protect the teenager through the age where they're at the highest risk. There is also a vaccine called the MenB vaccine that teenagers and young adults, 16 through 23-year-olds, should get, preferably around that 16 to 18-year-old range. And people do need multiple doses of the MenB vaccine for the best protection. So there are commercials that you may have seen on TV where it's, there's a mom and she says, "I never thought I would have to change his diapers again." And you see a teenage boy lying in the bed requiring full-time around-the-clock nursing care as a result of contracting meningitis and the brain damage that resulted from that. Okay, so we're going to stop here. The next thing is rotavirus. We should be able to finish this up tomorrow, and you will have everything. I know this is a lot of information, guys. I can't test you on all of this, so please don't panic. There's a lot of information on the test on pain management. There's quite a bit on your respiratory, the second part of our respiratory chapter, and then there's some questions related to the various vaccines. So try not to panic with this. Just I want you to embrace it and understand it, and I think it's very interesting. Save it, refer back to it, because I know it's a lot of information, but it's important to me to give this to you. I could trim it down. I know I could. But it's important to me that you understand the significance of why we have vaccines and what we are protecting our children from. I don't think that we really get it. I don't think that we understand that. I feel like we live in a bubble in the United States, that many of us live in a bubble, and we don't realize what's going on worldwide in nations that do not have access to these vaccines, what children today, right now, this hour, are experiencing. And I just want us all to be grateful for where we live and understand that that we're protected because of vaccines. So anyway, I'll catch back up with you tomorrow. Goodbye.